Okay, we'll get started. So today we're going to be talking about everything above the posterior fossa. And when we say that, we mean brainstem, cerebellum. So this is subcortical central nervous system. And so the three areas that we'll cover here in this lecture are diencephalic structures, basal ganglia, and white matter. And we won't say a lot about white matter. We're mainly going to focus on the internal capsule and an interesting lesion that can happen of the corpus callosum. All right, so remember that the largest part of the diencephalon is the thalamus. And so when we did our gross brain section here, we pointed out the thalamus here on the midline. And so remember that the third ventricle separates the right and left thalamus. And that lateral to the thalamus, we have the internal capsule. And more specifically, it's the posterior limb of the internal capsule that separates the thalamus from the putamen out here. Okay, and then here's the genu up here. All right, so we're going to go through the individual thalamic nuclei, and I'll just be honest, this is maybe not the most fascinating part of neuroscience, learning all of the thalamic nuclei, but just something you need to know, and I'll try to highlight the ones that are, I think, would be most often to be asked on board. So first of all these individual thalamic nuclei, and surrounding the thalamus, we have what's called the external medullary lamina. It's white matter that is around the thalamus. And then that's not really shown here. We can see the internal medullary lamina here. It kind of divides the individual thalamic nuclei. And I'll say a little bit about the function of the external and internal medullary lamina. But we're going to kind of go through these, starting with the anterior nucleus of the thalamus, the dorsomedial nucleus, and we'll kind of work our way around like this. Several of them we've talked about already, all right, and then some of this will be new. So first, the anterior nucleus of the thalamus. This is one we've talked about already. It's part of Papes circuit. Remember, Papes circuit has some role in laying down new memories. So it goes from the hippocampus out here in the temporal lobe. And so remember, these are the columns of the fornix here, down to the mammillary bodies, and up to the thalamus. And the specific nucleus of the thalamus here in Papes circuit is the anterior nucleus of the thalamus. And then up to the cingulate gyrus, and then back down to the hippocampus. Now, probably not important. There's a little bit from the hippocampus that kind of goes directly to the anterior nucleus of the thalamus, but most of it is getting there via the mammillary bodies and then up to the cingulate gyrus. Okay, so the anterior nucleus of the thalamus, you'd want to associate that part of the thalamus as having some role in memory, cognitive function. All right, so that's part of the limbic system. Remember, the cingulate gyrus is part of the limbic system. Hippocampus is part of the limbic system. So the other thalamic nucleus that's part of the limbic system is the dorsomedial nucleus. Now, it's not shown here, but this is an important communication or link between the amygdala, which remember is also in the temporal lobe here, just anterior to the hippocampus, and the prefrontal cortex. Okay, so after this test cycle, we have 2 hours on the anatomy of the limbic system, and we'll talk about emotions and memories and all of that. But the dorsomedial nucleus then of the thalamus is very important with regards to the amygdala and its communication with this large portion here in the frontal lobe called the prefrontal cortex. All right, so we oftentimes will lump these two thalamic nuclei together and call it the limbic thalamus. And so the limbic thalamus is the anterior and the dorsomedial thalamic nucleus. Okay, so again, this is limbic thalamus, anterior nucleus, dorsomedial nucleus. All right, now we also have some lateral thalamic nuclei out here. And so the pulvinar, you can see, is a very large portion here of the thalamus, is the pulvinar, and we kind of lump the lateral posterior nucleus of the thalamus together with this because they both seem to have really the same function. So the pulvinar and lateral posterior nucleus are very important for eye movements. And so they get information from the superior colliculus back here. Remember the superior colliculus we've said has to do with vision. And the only example I've given you so far is the tectospinal tract. Remember, that's the pathway that goes from the superior colliculus down to the cervical spine that allows you to turn your head appropriately to a visual stimulus. Well, here's another function of the superior colliculus. It communicates with visual association cortex, right? So visual areas of the brain in the occipital lobe and surrounding the occipital lobe. And so the thalamic nucleus, how the superior colliculus communicates with visual association cortex, is via that pulvinar nucleus and the lateral posterior nucleus. And so this is sometimes called an extrageniculate visual pathway. Remember that the lateral geniculate nucleus, that's the one we've talked about for visual acuity, right? Lateral geniculate is when you see something, you're using the lateral geniculate and then the optic radiations. This is separate, so that's why it's called an extrageniculate pathway. And it appears to be especially important for tracking things in space, so kind of pursuit movements and localizing things in space. All right, so the superior colliculus here is important for that. And again, it's the pulvinar and lateral posterior nucleus that are the thalamic nuclei that are involved. Okay, so pulvinar, lateral posterior nucleus, and here the arrow, it's going to posterior association cortex, or maybe we could better say visual cortex. Okay, so limbic thalamus is back here. Pulvinar, lateral posterior nucleus, important for eye movements. Back in this area, we have the ventral anterior and ventral lateral. So notice this is going to the motor cortex of the brain. And so both of these are the thalamic nuclei that are involved with regards to the basal ganglia and the cerebellum. Okay, so we're going to, at the end of this lecture, we're going to go over basal ganglia circuitry. Okay, and so we'll see that when the basal ganglia talks back to the motor cortex, it does so through the ventral anterior nucleus of the thalamus. The ventral lateral is the nucleus that's used by the cerebellum. That was from our last lecture. So all of that output from the cerebellum to the motor cortex goes through the VL primarily. Now this would probably be the most often asked thalamic nucleus, which we've mentioned several times in class, the VPL. So make sure you can remember that one for boards, because the VPL gets all the sensory information from the extremities, and that's whether it's pain and temperature, spinothalamic tract, or vibration and proprioception via the posterior columns, medial lemniscus. Okay, so all of that information from your arms and legs is going to the somatosensory cortex. Remember, that's post-central gyrus, but it gets there via the VPL. All right, another one we haven't talked about, but this would be often, I think you're maybe asked to contrast between these two. The VPM is really the same thing, except now it's for the face. Okay, so all that pain, temperature, vibration, proprioception, anything for the face gets to the post-central gyrus via the VPM. All right, and also taste information from the solitary nucleus and tract. That relays through the VPM. So you want to associate this with facial sensation and taste. And so here's just a little diagram. We've been through this in quite a lot of detail. So remember that down in the medulla here, we have the spinal trigeminal nucleus and tract, which is a continuation of the substantia gelatinosa. So it's pain and temperature for the face. And so that information, just like all sensory information, it crosses. And so here we see these crossing fibers that are going up to the thalamus. And this is not labeled here, but this is the VPM of the thalamus. And so this pathway is called the trigeminal thalamic tract. It's going from the trigeminal system up to the thalamus, sometimes called the trigeminal lemniscus, which is just lemniscus is just a name for a pathway. Okay, so this would be pain and temperature crossing over. And then up here we have the main sensory or chief sensory trigeminal nucleus. Remember, that's the one that's involved in the corneal reflex. And so that's vibration, tactile sensation. That also crosses over as part of the trigeminal thalamic tract. Again, for now, the important point is it's VPM, is the thalamic nucleus for facial sensation. Okay, and this one I don't care that you know, but there's for the vestibular system, anything that goes through the thalamus, remember, except for olfaction, or anything, that's communicating with the brain, has to go through the thalamus, except for olfaction. So vestibular input goes there as well, but I don't know why I included that. You don't need to know VPI. Now here's a clinical application, probably the most important clinical application for now about the thalamus. If you have a stroke in the thalamus, and so here's the normal side. We can see the internal capsule, so this is the posterior limb. There's the right thalamus, the right putamen. And so here we have an acute stroke here in the left thalamus. And so this can, over time, result in what's known as the thalamic pain syndrome. And so this is contralateral, often a burning, stinging, very uncomfortable sensation on the opposite face, arm, and leg. And so the thalamic nuclei that are mainly involved here are VPM and VPL. VPM, remember, for the face, contralateral face, VPL for the opposite arm and leg. And so patients that have this kind of stroke acutely will have sensory loss on the opposite side of the body, face, arm, and leg. And then often over time that kind of transforms into this uncomfortable, sunburn, stinging, numb, tingly feeling on the opposite side of the body. Okay, so that's our thalamic pain syndrome. These patients, because it doesn't involve, here's the posterior limb of the internal capsule, that is spared, so these patients don't have weakness. Their walking is pretty good, but they have just a loss of sensation on the opposite side of the body. And again, it's often painful. Okay, so practically VPL, VPM are the thalamic nuclei that are involved in that syndrome. Now the lateral and medial geniculate, we've talked about quite a bit. So those are thalamic nuclei. And so the lateral geniculate, along with the VPL and VPM, this would be your super high yield thalamic nucleus for board questions, because remember, that's the one involved in vision and visual acuity. So vision that comes back here through the optic nerve, chiasm, and optic tracts. Okay, so that synapse is on the lateral geniculate and then goes back to visual cortex. Okay, so the lateral geniculate certainly is involved in visual acuity. Now this one drawing also nicely shows here the superior colliculus. So remember, superior colliculus, this is not visual acuity. This has more to do with tracking eye movements. And so this just shows here the connection between the superior colliculus and the pulvinar. So remember, the pulvinar then is involved in that ability to track and to localize objects in space. Okay, the medial geniculate has to do with sound. And so this is kind of a condensed drawing here. Dr. Kirby has an hour to go through all of the auditory pathways with you, but we've mentioned here in the inner ear, the cochlea, that this enters via the eighth nerve into the cochlear nuclei. Remember the superior olivary nucleus from our brainstem lecture, that's the part that's involved in sound localization, that we can so accurately localize where things are in space based on auditory information here. And not labeled, but we mentioned in the brainstem lecture that auditory information, it travels up through the brainstem, goes through the lateral lemniscus. Okay, medial lemniscus, vibration proprioception. Lateral lemniscus is auditory information. Okay, and we showed how that synapses in the inferior colliculus. Remember, inferior colliculus has to do with sound. And then up to Heschel's gyrus. Okay, but the thalamic nucleus on the way for auditory is the medial geniculate. Okay. So in our brain dissection lab, we showed the lateral geniculate having the Napoleon's hat, okay? And someone asked me in lab what that was, and so I thought, okay, well, here we go. So there is the Napoleon's hat, all right? It has a similar shape. And so the medial geniculate never is that obvious, but you can see it right here. There is a nucleus that is medial to the lateral geniculate, so that's the medial geniculate. So again, lateral geniculate, visual acuity, medial geniculate for sound, and then information here gets relayed to Heschel's gyrus. Okay, so the other thing to say then about the thalamus is that within the internal medullary laminae, there are several nuclear groups. The only one we'll talk about here is the centromedian nucleus right here. And then remember that there are external medullary lamina that are all the way around the thalamus. And so these are, we could call them GABAergic. Remember, GABA is an inhibitory neurotransmitter. And so the reason we have this external medullary lamina all the way around the thalamus is that your thalamus, we've said, is the executive secretary. It determines what is important enough for your cortex to receive. And so at certain times you want to get a lot of information. I gave you the example of waking up in the middle of the night and you hear something outside and you want to be flooded with all sensory, visual, sensory information, everything, sound. And so then your external medullary lamina are going to allow everything through the thalamus, right? Gateways will be open wide. If, however, like in a lecture or something where you're really wanting to focus and concentrate, you don't want the thalamus bombarding you with every little bit of information. So then these GABAergic pathways around the thalamus will shut things down. So maybe we can just focus on cognition at that moment. Okay, so the external medullary lamina regulate what gets into or out of the thalamus, and this is the only thalamic nucleus that doesn't project to the brain. It's just a local circuit. They're kind of a gateway function. Okay, the only intralaminar nucleus that we'll talk about here is the centromedian nucleus, and this is a very important nucleus for pain. Okay, so our lecture on pain is later, but there are ascending pain pathways, and the slow pain pathways relay up through the centromedian nucleus. A pathway I didn't point out in the spinal cord because it's not that easy to see, but it's called the spino-reticular tract. It conveys pain information, goes through the reticular formation or the reticular activating system in the brainstem, which is very activating. Okay, this is why next year we'll talk about in the coma lecture that when we're trying to get someone in a coma to wake up a little bit, we need to give them a little painful stimulation. And we'll talk about ways of doing that that are obviously not harmful for the patient. But when we give painful stimulation, we're activating this spino-reticular tract via the reticular formation, which activates the entire brain. Okay, and it does so through the centromedian nucleus. Okay, and this thalamic nucleus is rather unique. Everything else we've talked about has a very point-to-point relationship for vision, for sound, for sensory information. It's going to a specific area of the cerebral cortex. Pain information that goes to the centromedian nucleus is not like that. It actually floods the whole cerebral cortex. Okay, so it's non-specific in its connections with the brain. Okay, and I'll mention that in basal ganglia circuitry, there's also the centromedian has a role in circuitry, the basal ganglia as well. So here's pain information from your arms and legs and maybe your face as well, going through the reticular formation. Okay, and it goes up to the centromedian nucleus, which, this is the area of the thalamus, so it's somewhere in here. And from there, it projects to the entire brain. Okay, so again, it's a little different, very non-specific in terms of its communication with the brain. Yes? Oh, yeah, I haven't heard of that. That sounds horrible to have something stimulating a patient like that. But yeah, that certainly would be. And that's why, well, I'll give you an example. To activate someone in a coma, we'll take our reflex hammer and we'll push down on the nail bed. And you can imagine that would be uncomfortable, you know. And so, or you can take a little cotton swab and put it in the nose and the nasopharynx and you twist it around a little bit. It doesn't cause any damage at all, but you can imagine that's quite irritating, right? So we're not trying to be mean to patients, obviously. We're wanting to get some information in the emergency room to find out where's the problem, right? And so when you give that painful information, you know, you're really activating the whole brain. That's why it's good, you know, a patient, for example, they may grimace, and if you see only one side of the face move, well, you just got some information. There's some weakness on the other side of the face. So we give pain to try to activate the nervous system and see what the patient does. Okay, so here's a summary of the thalamic nuclei, and let me just kind of highlight what I would say here are the highest of the high yield. So definitely VPL and VPM, you've got to remember those. VPL is all sensation for the arms and legs. Pain, temperature, vibration, proprioception. VPM is for the face, of course, but same thing, all facial sensation, and the VPM is right adjacent to the VPL. Lateral geniculate, you've got to know that's for visual acuity, so if we've got a lesion there, we'll have a significant visual loss. Medial geniculate, we mentioned several times, is important for auditory. Okay, and then I would say that probably the parts of the limbic system, anterior and dorsomedial nucleus, would be pretty high yield as well. Now, I'm not going to go through the other parts of the diencephalon. Dr. Kirby has an hour lecture on the hypothalamus, okay, but I just will remind you here that the pineal gland is the most important part of the epithalamus. And so remember, if we have a tumor there, it compresses on the dorsal midbrain. Remember, that's an important area for vertical eye movement, so a patient will have a hard time looking up and down. Remember, these are the patients that get that contraction, nystagmus, when they try to look up, the eyes come together. Okay, so that was just a reminder about Parinaud syndrome. Okay, and another nice look here of the thalamus and its relationship here to the posterior limb of the internal capsule and the genu, and there's the third ventricle. Okay, so let's just go back here and show you the same slide you're familiar with, the internal capsule. Okay, so remember that our posterior limb has two very important pathways, one motor, one sensory. The cortical bulbar tract is at the genu, and then we'll discuss here these three pathways that are in the anterior limb of the internal capsule. Okay, and the reason I'm coming back to this is that two of our most common stroke syndromes involve understanding the anatomy here in this area. So remember, the cortical spinal tract is in the posterior limb of the internal capsule. Okay, and so this is our descending classic upper motor neuron pathway, but right adjacent to it are the superior thalamic radiations. And so all of that information from the spinothalamic tract and the medial lemniscus that synapsed in the VPL and VPM, this is now going up to the postcentral gyrus through the superior thalamic radiations. Okay, so if you had a lesion here, you would affect all sensation in the opposite side of the body, face, arm, and leg. Okay, but what's interesting is that these two pathways, although they are immediately adjacent to each other, are in completely different vascular territories. They're supplied by different blood vessels. And so when we get to the stroke lecture next year, I will tell you you can have a lesion here that affects motor, but it usually spares the sensory pathway that is right adjacent to it. Okay, the cortical bulbar tract is here at the genu, and so remember, this is the pathway where the cortex communicates with the brainstem. And then here in the anterior limb, we have three pathways. Most of the cortical pontocerebellar tract, okay, that we've talked about quite a bit, goes through the anterior limb of the internal capsule. The frontal eye fields that are involved in horizontal eye movements, travels through the anterior limb of the internal capsule. And here are the anterior thalamic radiations. Okay, and this is the pathway involved in PAPE circuit. This is the one that goes from the anterior nucleus of the thalamus up to the cingulate gyrus. Okay, so really 6 pathways that you need to know about here that are traveling in the internal capsule. 3 in the anterior limb, only 1 at the genu, and then these 2 here in the posterior limb. So let's talk a little bit about that vascular distribution, because this is really important. Probably the most common stroke of all is this one, and it involves these penetrating branches here that come off of the middle cerebral artery. Okay, and these are called lenticulostriate arteries. And these lenticulostriate arteries supply, most importantly, the motor fibers that are in the posterior limb of the internal capsule and also the cortical bulbar tract at the genu. Okay, and so if we have an occlusion here of a lenticulostriate artery, then a patient can have what's known as a pure motor stroke. And so a pure motor stroke, again, very common. I think, you know, when you spend your month on neurology, and most of you will have 2 weeks on the inpatient service, most of you will see this. And so a pure motor stroke involves the cortical spinal tract and the cortical bulbar tract. Okay, and so the blood vessel involved is a lenticulostriate. And so these patients present acutely with weakness on the opposite side of the body, opposite arm and leg, that's cortical spinal tract. And from involvement of the cortical bulbar tract, they have contralateral lower facial weakness. Remember, lower facial, that's an upper motor neuron facial weakness. Okay, but that's all they have. Okay, the lenticulostriate does not supply these superior thalamic radiations, and so patients don't have sensory loss, they don't have visual loss, they don't have language problem, they don't have anything else. They just have one problem, which is they have weakness on the opposite side of the body. That's why we call it a pure motor stroke. And so if you see a patient like that who presents just with weakness on one side of the body, we can be very confident before a brain scan that, yep, we're going to find a problem right here. Posterior limb of the internal capsule and extending to the genu. Now, I need to have a student make a drawing of this for me, because this isn't a very good one, and I stole this. But so here is the middle cerebral artery. These are the lenticulostriates. Now, this is the posterior cerebral artery here, and it has branches here that are called thalamo-geniculate, and these supply the thalamus and the ascending sensory fibers. And so if we have a problem with the thalamo-geniculate, then you have kind of the exact opposite of the pure motor stroke. Now we have a pure sensory stroke. Okay, so these patients that occlude this blood vessel, thalamo-geniculate, have sudden onset loss of sensation on one side of the body. They're not weak. They don't have any other problem. They just have loss of sensation in the opposite face, arm, and leg. Okay, and so the lesion is usually here in the thalamus. So we have our stroke in the thalamus. These are the same patients that can get that thalamic pain syndrome over time. Okay, so the pure sensory stroke, the 2 thalamic nuclei you want to associate that with are VPL. Okay, so that'll affect the opposite arm and leg, and VPM, that'll affect the opposite face. Okay. So again, pure motor stroke is lenticulostriate, which involves corticospinal and cortical bulbar. Pure sensory stroke is thalamo-geniculate, and the stroke is here in the thalamus, affecting VPL and VPM. Okay, so here's your familiar picture here on the cortical bulbar tract. So we've just pointed out that it's in the genu of the internal capsule. And remember, the cortical bulbar tract is controlling all of the brainstem lower motor neurons. Okay, anything that has to do with moving your tongue, hypoglossal, or talking or swallowing, nucleus ambiguous, or moving your face, or chewing. That's all the cortical bulbar tract. And so remember, the importance here is that it talks to both ipsilateral and contralateral lower motor neurons in the brainstem, with the exception that we don't have an ipsilateral and contralateral or an ipsilateral supply here to the part of the facial nucleus for the lower face, right? So that's why we get a lower facial weakness with the lesion of the cortical bulbar tract, okay, on the opposite side. But there's one other interesting thing. Well, here's maybe a better diagram just for illustrating that. So we've shown this already. Here's the cortical bulbar tract. Okay, so again, if we've got a stroke here in the GNU, or we have a pure motor stroke, the real problem here is that you lose that supply to the lower face because it doesn't have an ipsilateral connection. Okay, so in our central 7, the patient has a lower facial weakness, unlike a Bell's palsy, which is going to affect the whole side of the face. Okay, but here's something else that's interesting about the cortical bulbar tract. If you have, and these are usually patients that have lots of stroke risk factors. They have diabetes, they have hypertension, and over time they have many strokes that just pick away at the cortical bulbar tract. So you're losing more and more and more connection between the cortex and the brainstem. And over time that can lead to what's known as a pseudobulbar palsy. Okay, and pseudobulbar palsy, these patients usually have profound dysarthria and dysphagia. Okay, why is that? Well, just to go back here to the cortical bulbar tract, it's supplying the nucleus ambiguus and the hypoglossal nucleus. Those are very, very important for talking and swallowing, right? And so significant damage to the cortical bulbar tract, we lose our ability to innervate the nucleus ambiguus and the hypoglossal nucleus. And so patients have profound dysarthria and dysphagia. Because they've had lots of strokes, just involving a large portion of the brain, anything that results in significant bilateral brain damage causes memory loss, so these patients often have some degree of dementia. Okay? And any patient that has had lots and lots of small strokes, some of those are going to affect motor pathways or sensory pathways. So these patients have focal findings like hemiplegia, hemisensory loss, as you would see in any patient who's had a lot of strokes. But what usually makes us think about pseudobulbar palsy, maybe not the most flattering term here, but it's most often used, it's called emotional incontinence. And what that means is these patients have great difficulty controlling their emotions. And so that can result in just inappropriate laughing. You know, something happens, not that funny. They will tell you it wasn't that funny, but I just could not stop laughing. And or more often, it's crying. You know, so they'll be watching something on TV, you know, it's kind of cheesy, it's a little sad, and they'll just weep. And they're embarrassed because it's not that sad, but they lose that ability to control their emotions. And so this is the full kind of constellation here of what's known as pseudobulbar palsy. And so the pathway you want to associate with when you have a patient with pseudobulbar palsy is the cortical bulbar tract. So almost always it's lots and lots and lots of subcortical strokes affecting the cortical bulbar tract. Okay, so here was a patient that we saw just recently with this, and he kind of describes a little bit what it's like with this.
You laugh, or when things aren't very sad, you still cry. Can you tell us a little bit more about that?
Yeah, I get very emotional about certain things, or I laugh at things that shouldn't be laughed at.
And you can hear his voice is a little bit dysarthric, right? It's a little bit of slurred speech.
You know, I'll be watching a movie with my wife, and something sad comes on, and I start laughing at it, and she'll call me mental, or you know, what's wrong with you? You're crazy. And I thought I was, but I'm not. It's part of the sickness, you know, I had off and on. And I used to have anger outbursts too. And, you know, when you have a stroke, your whole life changes. And whoever your spouse is, their life changed just as much as yours. So it's not just me, it's her too. That her life changed. Like right now, she's got to take care of me. And you don't know how frustrating.
So usually these patients, you know, you're seeing them in the hospital for their stroke, and that's emotional, right? We would all experience emotion in that, but we could, you know, hold it together perhaps. These patients, anything that touches on an emotional subject, they start crying. And so we'll talk next year. There are actually some good treatments for pseudobulbar palsy. So usually this is something with medications. Patients are able to hold their emotions together a little bit better. But it can be quite embarrassing to them because they're just crying or laughing frequently at all kinds of things. Yes? Why do they have pseudobulbar palsy? Yeah, that's a good question. It's not entirely, I don't think we have a clear understanding of the mechanism of that. Yeah, as I said, it's not entirely clear why, because cortical bulbar, we're just losing that connection with the brainstem. Why should that affect your emotions to such a degree? It's a good question, but I don't have a good answer for you. There's several things in neurology. We could just say, you know, that's the way it is, but we don't have all the answers with regards to brain pathways. Let me just mention in passing here, multiple sclerosis. We had a case study on this. I've used multiple sclerosis several times as an example of a condition that affects specific pathways like the medial longitudinal fasciculus. But I just have to mention here, as long as we're talking about white matter and pathways in the brain, that MS will be our classic condition of a central nervous system demyelinating disease. Okay, and I'm just using this opportunity to remind you that the optic nerves are a central nervous system pathway. And so they are frequently involved in multiple sclerosis. Okay, now here's something I didn't add to the curriculum until last year because this showed up as a question on the National Board Subject Exam, which amazed me because at the annual American Academy of Neurology meetings, I enjoy going to this. They have these sessions where you can, you know, use your clickers, and they find out who's the smartest neurologist by answering questions. And this was one of those stump questions. This was like the hard, you know, 5-level for a neurologist, a very hard question, and it showed up for first-year medical student National Board Subject Exam, which I thought was, yeah, I know. I'd like to know the test writing committee. But anyway, so that's why we're talking about it. Apraxia is something that we will talk about when we get to Alzheimer's disease. But let me just explain a little bit what an apraxia is. We have all of these motor programs in our brain, millions of them, for things that we do every day that you don't have to think about. Eating, brushing your teeth, shaving, you know, taking care of your hair. These are all things we can do automatically. Just today I was driving next to someone in for this lecture, and she was eating and doing her makeup at the same time. And so these are all motor programs that we have that get laid down for activities. So we can, you know, often multitask and do all of these things because of these motor programs that are there. An apraxia is where you lose some of these motor programs. And so Alzheimer's next year will be our classic condition that results in an apraxia because the whole brain degenerates in Alzheimer's disease. And so tasks that we take for granted, just like dressing or eating, become difficult for someone with Alzheimer's because that program isn't there perfectly anymore. And so they will sometimes, you know, in an advanced Alzheimer's, will take a fork, for example, when they're eating, and they just don't remember what to do with it. How do I manipulate that fork to get food on it? Or how do I brush teeth? So an apraxia is a loss of a previous learned motor activity, but it's not due to weakness. Okay, it's not that they can't hold on to the fork or they don't have the strength for it. It's not due to sensory loss. They can feel their hand just fine. It's not due to visual loss. It's not due to ataxia. It's a loss of these motor programs. Okay, so you can have all kinds of apraxias. If we're checking for apraxia on exam, we'll just ask a patient to do things like pretend you have a toothbrush in your hand. How would you brush your teeth? Okay, well, we could probably figure that out. You know, put toothpaste on, and we would, you know, show how you brush your teeth. Again, if you've got an apraxia, you've lost the motor program, they just kind of, I can't figure out what would I'm going to do with the hand. I can't really show you. Or show me how you would flip a coin. You know, probably most of us haven't flipped that many coins, but we still know how it works, and you can show how you would do that. And so an example of a focal apraxia very rare, is a lesion here that involves the anterior portion of the corpus callosum. All right, so let's say that we ask a patient to flip a coin with their right hand. Okay, how do you understand what I just said? That's Wernicke's area, right? So please flip a coin with your right hand. You understand that in Wernicke's area, right? But, and I'm assuming that the patient is language dominant on the left hemisphere. Okay, so we're on the left side here. But to move your right hand, that's going to be motor cortex in the left hemisphere, right? So we need to get that command from Wernicke's area up to motor cortex, which is going to be up in this area. Okay, and so then we access the appropriate motor program, access motor program for coin flipping. Okay, and so here it is, left motor cortex, corticospinal tract, then we'll move your right hand and you can flip a coin normally. Okay, now the problem arises though if we have a lesion here of the anterior corpus callosum and now we ask a patient to flip a coin with their left hand. Now to flip a coin with your left hand you need to activate motor cortex in the right hemisphere, right? So please flip a coin with your left hand. Okay, the command is understood. And that information moves forward and it needs to cross over right here in the anterior portion of the corpus callosum. And so a lesion here prevents the information from accessing the right motor cortex. And so with the lesion of the anterior portion of the corpus callosum, the patient actually has difficulty moving the left hand to show how to flip a coin. Okay, so the answer then is a lesion of the anterior corpus callosum results in left hand apraxia. Okay, because the information to stimulate the right motor cortex, it can't get over. Right? And so the patient will kind of clumsily hold their hand and they can't figure out how to actually put the thumb as if they had a coin there. Okay, did that make sense? Yes. Yeah, so this is all predicated on the fact that, most people are going to be language dominant in the left hemisphere, certainly if someone's right-handed. If you had a left-handed individual, then, it could be the other side. But still, remember, statistically, most left-handed people are still language dominant on the left hemisphere. We do have a test where we can figure out which hemisphere someone is language dominant. It's called a WADA test, and you can put one half of the brain to sleep. And then you can basically find out if the patient can talk to you or not. If they can't, then you know you've just identified the language dominant hemisphere. Yes? So yeah, it could be, it's just the hand does so many more, the leg, yeah, it's involved in walking, but we don't have these, now people that are artists that have maybe lost an upper extremity that can draw with their foot, then maybe we'd have a better way you can access learned activities that they have with their foot. But it's the hand that's more easy to assess in terms of an apraxia. But you certainly could have problems, with the opposite leg as well. Yeah. Any other questions on that? Yes? Say just a bit louder. Could they repeat the motion in the other hand? Is that what you asked? Oh, well, one thing is, so there's a difference in just spontaneous activity. Like, you're not thinking about it, right? And we're just naturally, we're writing, we're brushing our teeth or whatever. But the lesion here tends to be mainly with when we now are formally asking a patient to do something, which now involves going through this whole kind of a circuit like this. So it's a little bit different. This patient may actually do better with a lesion here just in natural day-to-day activity because now this can kind of be operating kind of independently. So it's a little more obvious when we ask them to do something via an auditory command because that has to cross over. Okay, so very important here, and probably for me the most practical part of this lecture we need to cover here in 5 minutes is basal ganglia circuitry. We will apply this next year in our lecture on Parkinson's and movement disorders, And there really is a payoff to understanding this. So remember, what are the different parts of the basal ganglia? We have the caudate and the putamen. Remember, these two areas are called the striatum because they function together. Medial to the putamen, we have the globus pallidus. And can you see there's a little separation there between the internal and the external part of the globus pallidus? Okay. We also have the subthalamic nucleus right here. Okay, and so these are the areas that we'll talk about here in basal ganglia circuitry, and of course we can't forget the substantia nigra right down here. Okay, so I would not ask you to know this again unless there was a good reason for it. And so let me tell you what we've done so far with the basal ganglia. Remember we said that when the motor cortex talks to the basal ganglia, it talks to the striatum. And the striatum is the caudate and the putamen. Okay, and I told you that there's this basal ganglia circuitry, that's what we're going to talk about now, and that the output nucleus of the basal ganglia is the internal segment of the globus pallidus. And that wasn't entirely true because there's a part here called the substantia nigra pars reticulata that also is the output nucleus. So here's the substantia nigra pars compacta. This is the most important part of the substantia nigra for you to know about because this produces dopamine. Okay, but there's another part of the substantia nigra that functions together with the internal segment of the globus pallidus. And so this is our output nucleus that goes back to the motor cortex, okay, through the basal ganglia. So remember, it's the VA is the nucleus of the thalamus for the basal ganglia circuitry. All right, so how I remember this is anything that comes from the cortex or goes to the cortex uses glutamate, which is an excitatory neurotransmitter. Okay, whereas almost all of the circuitry here within the basal ganglia uses GABA, which is an inhibitory neurotransmitter, okay, with one exception. So let's follow dopamine here as it projects from the pars compacta up to the striatum. Okay, so remember, this is what degenerates in Parkinson's disease. So there's an interesting thing here. As dopamine goes up to the striatum, it has a different action depending on which receptor it's talking to. D1 receptors, dopamine 1 receptors, are stimulated by dopamine. Okay, and so we call this circuit here the direct pathway because it goes directly from the striatum to the output nuclei. Okay, so this stimulates D1, and then we have GABA here inhibiting the output nuclei. Dopamine on the D2 receptors in the striatum inhibits them. This is interesting. Okay, and so we call this the indirect route because there are two steps in between these D2 receptors and the output nuclei. And so the indirect route goes through the external segment of the globus pallidus and the subthalamic nucleus, and from the subthalamic nucleus to the output nuclei. Okay, so I said everything in the internal circuitry here, the basal ganglia, is GABA, so just plug in GABA everywhere, with the exception that output from the subthalamic nucleus is glutamate, which is stimulatory. Okay, so I have just arbitrarily here, anytime I have glutamate, it's stimulatory, so I add 2 positive marks. And anytime we have GABA, I put 2 negative marks. And so the importance of this, and it really does work very well, is that when we have lesions of the basal ganglia, and you kind of map this out, what's going to change, the rule of thumb is if the lesion results in less glutamate going back to the motor cortex, then the patient slows down and they look like they have Parkinson's disease. Okay? If we have a lesion in the basal ganglia circuitry that results in more glutamate going back to the motor cortex, now we have exactly the opposite. We have what's called a hyperkinetic movement disorder. The patient is moving too much. Okay? And so let's give 2 examples here. Let's say we have Parkinson's disease. And so we have degeneration of the pars compacta substantia nigra. Okay, so let's first follow this through the direct route. If we have less dopamine being produced, we're going to stimulate the D1 receptor less. So I took one of the positive marks away. If we stimulate the D1 receptor less, it's going to put out less GABA. And so we're going to have less GABA inhibition of the output nuclei. If you inhibit the output nuclei less, then they're going to crank out more GABA going through the ventral anterior nucleus of the thalamus. It's going to inhibit that more, and so we're going to have less glutamate going back to the cortex. Patient slows down. Okay, so they can't move well. The same thing happens if we go through the indirect route. So again, we have less dopamine being produced. So now we inhibit the D2 receptor less dopamine. So if you inhibit this less, it's going to put out more GABA, which is going to inhibit the external segment more. So it's going to put out less GABA. So now we inhibit the subthalamic nucleus less. So it's going to put out more glutamate. We stimulate this more, and again, that's going to put out a lot more GABA, and we're going to even further shut down glutamate stimulation of the cortex. And so both through the direct and the indirect route in Parkinson's disease, you end up with less glutamate going back to the motor cortex. And so this helps us to understand why someone slows down with Parkinson's, but as we'll see next year, we can also tell where do you want to put, when we talk about deep brain stimulation, a surgery for Parkinson's disease, this tells us where we want to put the deep brain stimulator. That's for next year. Let me give you an easier example. We've said that a stroke in the subthalamic nucleus results in hemiballismus. Now that's an excessive movement. We call that a hyperkinetic movement. It doesn't look anything at all like Parkinson's disease. So if we have a stroke here, then that's going to destroy this nucleus. It's not going to put out very much glutamate. Okay, so we're going to stimulate the output nuclei less. And so they're going to put out less GABA, less inhibition of the ventral anterior nucleus of the thalamus. And so therefore, a lot more glutamate going back to the motor cortex. And so now we get an excitatory movement disorder where one arm and leg is wildly flinging. And so that's known as hemiballismus. Okay, any questions on the basal ganglia circuitry? All right, have a good day.